Good evening, everybody. I hope you can all hear me and see me. Welcome to this webinar, Aging Well with Cerebral Palsy. We're delighted to welcome you all from wherever you are. Today, especially, it's Cerebral Palsy Awareness Day, the culmination of March being Cerebral Palsy Awareness Month. My name is Stephanie Fraser. I am the Chief Executive of Cerebral Palsy Scotland. And as I say, we are delighted to welcome you. A little bit of housekeeping. Please, will you make sure your microphones are muted? If you feel able to, please turn on your camera if you're speaking or want to give a reaction, be it a thumbs up or a wave or something like that, if you like something. I know from experience of presenting these things that it's really good to get some reactions rather than just thinking you're presenting to a screen. So please do use the reaction button.
One calling.
Sorry, and if you could mute, please, that would be really helpful. What we're going to do, just a little bit about Cerebral Palsy Scotland. For those of you who don't know us, we're based in Scotland, in Glasgow. We help people with cerebral palsy, any type of cerebral palsy, any age, all across Scotland. We do that by providing information and support, and we campaign about issues that make the world a better place for people with cerebral palsy. Particularly for adults, we offer specialist reviews to any adult who maybe haven't seen anybody for a long time, or just want to check in about where they are with their health. And we offer regular therapy through our Helping Hands programme. All of these programmes can be found on our website, www.cerebralpalsyscotland.org. We also, just a date for your diary, we run the only conference focusing on cerebral palsy. It's this year. It will be on the 8th of October, which is a Wednesday, very close to World Cerebral Palsy Day, another great date for your diary. Details are on our website, so please sign up to that. If you're not able to get to Scotland, please sign up to our newsletter via the website. Keep informed with what's going on, and keep an eye out for future webinars and other online and in-person events as well. So as I say, it's a joy to welcome you all tonight, and we are extremely fortunate to have with us Dr. Kirsty Colquhoun. Kirsty Colquhoun has been a trustee of Cerebral Palsy Scotland since 2019. She is actually a consultant in geriatric medicine and general internal medicine, and works in NHS, Greater Glasgow and Clyde, at the Glasgow Royal Infirmary, Stob Hill, and the Beats and West of Scotland Cancer Centre. She doesn't just have those jobs, she has a number of other jobs. She is also honorary clinical senior lecturer at the University of Glasgow. She has a special interest in falls and developing cancer services for older adults. She's the secretary of the British Geriatric Society Geriatric Specialist Interest Group and a fellow of the Royal College of Physicians and Surgeons in Glasgow. So I cannot think of anyone more qualified, and I am more excited to be able to welcome and hand over to other than Kirsty, who is a great friend to us all, and we really appreciate her giving up her time in her very busy schedule to be with us this evening to talk about aging well. Before I hand over, just to say that Kirsty will talk us through about the impact of the aging process, the barriers, societal barriers, and positive steps we can all take. If at the end there will be some time for questions, we ask you please put any questions you have in the chat function. Members of the Cerebral Palsy Scotland team will be monitoring the chat function, and when Kirsty has finished presenting, we will go first to the questions in the chat. So hopefully after all these years, you're familiar with the chat function and are able to put questions in that as we go along and as they occur to you. And then if we have time, we'll try and open it up to the floor, but we may not have time. So please use the chat function. But Kirsty, thank you again for being with us, giving up your time, and over to you.
Thank you very much for having me. So as Stephanie said, I'm going to be talking about aging well with cerebral palsy. I did this talk at the Cerebral Palsy conference last year. I had a really lovely day. It was really great to see so many people doing fantastic work around about cerebral palsy. And I said at the time, I'm kind of worried with this title that people think they're going to come on and I'm going to talk about like skincare regimes, because we all think of aging in a really negative way. And I did recognise someone that I knew from many years ago, and they didn't recognise me. And I said at the time, I'm maybe not the best person to be doing this talk if you're wanting to talk about not aging, because clearly they had aged better than me. So what we'll cover, we'll talk about the impact of cerebral palsy on aging and what we can do to age well as chatting a little bit about overcoming the barriers. I don't have all the answers. We certainly know that we don't have all the services that we would like. But I do hope that what this does trigger is some thought and some discussion that you can take back with you. I thought, just in case, I did advertise this to some of my GP, geriatrician colleagues. When we were learning about cerebral palsy in medical school, we learned about it in our paediatric block. For me, that was like 20 plus years ago. So for anyone out there that isn't familiar with cerebral palsy, just a little update. So cerebral palsy is when we have damage to the developing brain, either just before birth, during birth, or just after birth. So it's a condition that you will have from the very start of life. It is a broad set of conditions, a sort of umbrella term. I do talks to health boards to sort of challenge perceptions around about disability, so they can support people working in the NHS and also support patients who are disabled. And I say that what comes to mind when we talk about disability, because we need to be able to challenge our own connotations about things. And the same thing comes around about cerebral palsy. And I'm sure a lot of us know that people will very often underestimate what people with cerebral palsy can do. I went to Pilates class the other day. I've been going to Pilates for 20 years. I'm not great, I'm still in a beginner class, but I do it. And it was a new instructor, so I thought I better tell her that I've got cerebral palsy. And she said, "Oh, bless," as if, oh, this is strange, having someone with cerebral palsy in my Pilates class. So we're all aware of all these things, and it is a very broad set of conditions, but it will always disrupt the development of movement, posture, and there are different types and different ways we can describe it due to the different parts of the brain that it affects. So the most common type of cerebral palsy is spastic cerebral palsy. So that's when you get increased tone, tightness of the muscles. That's when it affects the motor cortex. We talk about ataxic cerebral palsy. That's when it impacts on the cerebellum. That particularly causes things like balance issues, coordination issues. And then dyskinetic is when it impacts a particular area of the brain called the basal ganglia. And within that, we might see abnormal movements. And sometimes people have a mixture of all of those. We tend to describe it in the gross motor function clinical scale, and it's grades 1 to 5. So grade 1 would be when someone can walk without any aids, they can still run, jump, get up and down stairs, but it will still have an effect on their movement, their posture, their balance. Grade 2, that would be things like if you needed a banister to get up and down stairs, you could still walk without using any aids, but you would struggle with things like jumping and running. And then we go up using whether you have to use aids, whether you have to use a wheelchair, whether you need help with the wheelchair, how often you have, whether you can use the wheelchair all the time, and whether you need help with things like head mobility and things like that. So there's a wide spectrum. There are a number of associated conditions, and not everybody with cerebral palsy will have these, but it may well affect your communication. It might impact on people's speech, and some people might need to use communication aids. Dysphagia, that's fancy word for swallowing, so it can impact on your swallowing. You can have things like secretions. There's associations with epilepsy, visual impairment. It can impact on continence, so that's things like being able to go to the toilet. There is an association with constipation, and then bladder symptoms, call it some neurological bladder. And then pain is very, very common. Probably about 75% of people with cerebral palsy will have pain, and there's different types of pain and different ways in which cerebral palsy can cause pain, and we will talk about that. For some people, there'll be associations with respiratory conditions, and there's a wide range of reasons why that might be. So if you have trouble with swallowing, then that can make you prone to something called aspiration pneumonias, which is a type of chest infection because things like secretions go down the wrong way. It certainly has an impact on sleep. And again, there might be a wide range of reasons why that might be. It might be because of pain. It might be because you have difficulty positioning yourself. And there is associations with mental health. So you're more likely to suffer from things like depression, anxiety, and that can also have an impact on things like sleep. So there's a lot of conditions that are associated with cerebral palsy, but not everybody will have. Some people might have none of those. Some people might have several. In terms of medicine, we look at neurological conditions in terms of being non-progressive or progressive. So non-progressive conditions are when the damage happens to the nervous system. So the damage happens to the brain in cerebral palsy, and that's the damage done. It's not going to get any worse. Progressive neurological conditions, when you might have continued damage. So for example, in dementia, in Parkinson's disease, although we can give medicines to try and slow down that damage and the symptoms. But even though cerebral palsy is not progressive, it's certainly not a static condition. And it's because of this recognition, or lack of recognition, rather, that it's not a static condition, that we run into problems with adult services. And again, we'll talk a little bit more about that. So just like the fact that no two adults or children with cerebral palsy are the same, even if you have the same type of cerebral palsy, whatever you do with your life will mean that the way that impacts on you will be different. So nobody's the same. No two older adults are the same. And there may be older adults who are in their 80s and out skydiving versus some older adults who are frailer, lots of health problems, functional difficulties. And I wanted to just talk a little bit about geriatric medicine. I'm a geriatrician, obviously, and I love my job. I wouldn't want to do anything else, but we've got a bit of a branding issue in that people don't like the idea of coming to see a geriatrician. They think we're going to put everybody in a nursing home, which in fact what we're trying to do is we are trying to allow older adults, particularly frailer older adults, to live with as high a quality of life as they can, as independently as possible. And we do that across a wide range of settings. So in my job, I would have an acute assessment ward, so that's poorly older adults who've come into hospital. We're still doing diagnoses, still doing treatments. I have a falls clinic. I say I do work with older adults with cancer to try and optimise them for treatment, or if they're not fit enough for treatment, trying to optimise quality of life. And we do that on the wards in the cancer hospital, working with the teams of physios and occupational therapists. And we do that everywhere, out of all settings, clinics. I see unwell people coming into the hospital and receiving, and then I do some medical school work and also lots of other bits and bobs, as Stephanie mentioned. So it's a wide, varied job. And other colleagues I work with will work in rehabilitation, which is something people with cerebral palsy are very familiar with. May well work with other neurological conditions like stroke, like Parkinson's disease. They may well work in the community. It's a very varied role. But if you do get referred to a geriatrician, don't be alarmed or scared of that. I think it's important that we mention what we mean by frailty, because when we're talking about ageing well, that's really important. And that's the kind of group of older adults that I tend to work with. So that's when your body systems gradually lose their inbuilt reserve and puts them at risk of an adverse outcome, which can be pretty dramatic, even after what we would see as a minor event. So let's say, for example, they had osteoarthritis and they got cocodamol and that made them constipated. They then can get delirium, which is a fancy word for confusion. They have a fall, they break their hip, they end up, it can all sort of spiral, if you like, because we don't have those reserves anymore. Just because you're older doesn't mean that you're going to be frail. Frailty can be associated in the younger population, but we don't do frailty screening in the younger population. The reason we do it in the older population is because we know we can help. Certainly disability is not, just because you're disabled, certainly does not mean you're frail, although there can be associations. Same as if you've got lots of health problems, it doesn't mean you're frail, but there can be associations. And it's important that we distinguish between all those things. So I'm not an expert in cerebral palsy. You saw in all that list of things, I didn't talk about cerebral palsy. So why on earth am I here talking, well, this is me when I was wee, and the eagle eyes of you might see that I have spots on. So I have cerebral palsy. I have spastic diplegia, so it affects my lower limbs, so it can affect one side of your body, hemiplegia, all four limbs, quadriplegia, and I'm diplegic, which means my lower limbs, and I would be sort of grade 2. So I walk without using any aids, but I would struggle with stairs and I can't really run. And I guess that means that I do understand the challenges that you face as you're getting older. So I didn't want my disability to define me, I guess, in my job, but as I progressed through my job, I realised that there was a real overlap between the challenges that the older patients that I was trying to advocate for had, with perhaps I felt as somebody with cerebral palsy. This was one of the prompts for developing services for older adults with cancer, and it was produced by NHS England, Age UK and Macmillan, and it basically was showing a number of things for older adults. Their outcomes were improving at slower rates compared to the younger population. There was inequalities in access to services. For example, they weren't seeing specialist nurses as much as a younger person with cancer might do. They were less likely to receive clinically effective treatment because there wasn't as many studies where older, frailer people were included, and cancer discrimination because you're older is against the law. And actually what we could do, if we took cancer out and we put older adults, we could put cerebral palsy in there, and we could put people with cerebral palsy, because we know we face a lot of these challenges, inequalities in access to services, lack of research in things that might help us. So got involved in a number of things, so trustee for Cerebral Palsy Scotland, and then these are as kind of a bit of a declaration of interest, which I need to put down some of the things that I'm involved in to try and tackle some of the inequalities that I see for disabled people and people with cerebral palsy. And all these roles are kind of out with my work, day-to-day work, if you like. So I have to, a lot of some of this data and that I'm going to talk about, I have to give credit to Emma Livingston. She's from UP, which is a cerebral palsy charity which lobbies and supports adults. This is Nick Watson, and he's a professor of disability studies in the University of Glasgow. And what we did was, for the British Geriatric Society, we put together a workshop looking at ageing, essentially like this, ageing well with cerebral palsy, because actually geriatricians weren't actually that familiar with how disability would impact on how you age and how they would deal with that when someone who has had a disability reaches their services. So in general, we know that the population has been ageing for decades and decades now, and you can see in the over 75 group, there's really been a significant percentage increase between 2014 and 2039. And this is a really positive thing because it shows that medical science has come on. It used to be if you had a heart attack, you were put to bed and you kept your fingers crossed and hoped you were okay. Now we have loads of medicines that we can give people. We can send them off for angiograms. We can put things up and scoop out clots. We can reverse heart muscle damage. There's lots and lots that we can do. Also improvements in things like vaccination. So we've got rid of things, certain diseases, improvements in sanitation. So lots of things. This is a really good marker of successes in science and public health, etc. But I suppose it does put strains on systems, and I think, what we probably don't have is a health and social care system which is used to having frailer older adults who are living with lots of health problems, who maybe need help with things like home helps, etc., to help them live independently. And that's something that those of us with cerebral palsy probably experience as well. And as I said, no two older adults are the same. And while it's really great that people are living longer, what we now really need to focus on is how do we help people live long, but also live well? And how do we reduce this burden on frailty for their own benefit, but also for the benefit of everybody? How can we, what can we do so that people are more like the skydiver rather than the person who's having to spend lots of time in hospital? So I guess you'll probably forget most of what I say, but the first point would be that we're all older adults in training. So there's all things that we can do throughout our lives that will help us be fitter in old age. And obviously some of it's down to genetics and some of it's down to luck. And I'm not sitting here saying that I am perfect in my lifestyle. I am 110% not, because, you know, that very few people are, but there's things that we can do probably before we're born, but certainly we're born, and if we're looking at it in the context of cerebral palsy as well. So why is ageing and cerebral palsy, ageing with a disability, relevant? Well, as I say, ageing starts from the moment that we're born. When we're young, we have plasticity of the brain, so that's why we do a lot of physiotherapy, occupational therapy, speech and language therapy when we're young with cerebral palsy, because we can see improvements at that point due to this plasticity of the brain. And when I was young, I did physiotherapy every day, I think apart from a Sunday, which I hated, like I absolutely hated it. But now I'm really glad because it's given me a baseline mobility which I've been able to take into adult life. Why cerebral palsy? Well, cerebral palsy is the most common childhood disability. It affects about 1 in 500 births. We think there's about 130,000 adults with cerebral palsy, but we're not quite sure because coding of it is a little bit funny. As an example of that, so the oldest person I've diagnosed with cerebral palsy was 87. They came to my Falls clinic. There was like nothing really in the notes, but when they were walking, they weren't using one side as well as the other. So I thought, well, wonder if they've had a stroke. Like, you know, and I no, I've had this all my life. And essentially they had hemiplegic cerebral palsy. And they'd never been told that. They were diagnosed with congenital hemiplegia. So that is the oldest person that I've diagnosed. And as I say, there is this issue with coding, which makes it a challenge when we're looking at what the needs are for the services, etc. What do we mean when we talk about ageing with a disability? Well, just because you're disabled doesn't mean that you don't have the same effects of ageing as somebody without a disability. So we need to consider that, but we also need to consider how that disability might impact on your ageing process and what we can do to support that. There's been massive changing in demographics. So now, I mean, historically, a large number of people with cerebral palsy would have died in childhood. Now that is very rare, and many people with cerebral palsy can live normal life expectancies. And not only that, but people with cerebral palsy are just getting on with their lives like everybody else. They are working, they're traveling, they're volunteering, they're participating in sports, you name it, they're doing it. But that does have an impact on your body because of the different ways in which we move. We also need to understand, there is also an increasing understanding of the importance of ageing well with a lifelong disability. So while this increase in life expectancy, while this has been going on for decades and decades, and this has been studied for decades and decades, it's probably only been over the past maybe 10, 20 years that this has been considered in the context of disability. So we're a wee bit behind in the research, but it is happening, and you can see this event that happened last year. We all know, all of us who are adults with cerebral palsy know when you transition from childhood services to adult services, sometimes there's like nothing to transition to. There's a real lack of services to support adults with cerebral palsy, but we do have an increasing body of guidelines and research into how we can support things, which does feed into this topic of ageing well with cerebral palsy. I think it's quite easy at the moment. So it's quite easy when you're disabled it can get quite a lot. Sometimes you've got all your physical challenges, pain, as well as all the challenges of trying to access healthcare, access social care, the stigma that you face, especially currently. You know, there's a lot of negative things going on in the world. COVID had an impact on disabled people. Cost of living has had an impact. So I think sometimes it is important to think about how far the disability movement has come, and in 70 years from now, how far it will have progressed again, and it will. And I love a little bit of history just to break up the boring medical chat. But this is Marjorie Warren. So she's the kind of mother figure of geriatric medicine, and the British Geriatric Society headquarters are called Marjorie Warren House. So this is really dated language. We wouldn't use language like this But essentially, she went into what we would call institutions. And within those institutions, she found older adults who were confused, who were sick. She found unmarried mothers were in there. She found what chronically young sick. And what she advocated for was getting these people into hospital, treating reversible things, rehabilitating people and getting them back into the community and participating in society, and not locking them, hiding them away, and not giving them the opportunity to optimize themselves. So she was a kind of mother figure of geriatric medicine, and it mainly was geriatric medicine, but it was also applicable to the disabled population. So we fast forward, and this was, I think, about 10 years ago, and this is Nick Watson's research. And Nick Watson was who I referred to. He has got a spinal cord injury, and he is a professor of disability studies in the University of Glasgow. He did some qualitative research. He looked at 26 adults with cerebral palsy. Now, in research, while in older age, we would talk about 65 and older, sometimes now 75. If you're disabled, somehow you're suddenly 55, you're classed as older adult. But he looked at people over 55, and a lot of people with cerebral palsy would say that they kind of wore out quicker. And there's a lot of discussion about premature aging, which personally I'm not a big fan of that term, because I think what we're seeing is secondary complications of disability. But that is, I think, what it feels like. And not one of those people were still walking at over 55. But more worryingly than that, not one of them was offered rehabilitation, which could have perhaps preserved their mobility. Now, sometimes as you get older, if you are experiencing increasing pain, challenges with walking, it might be that you decide to start using a walking aid or a wheelchair so you can maintain your independence. And that's totally fine. But if you want to be able to continue to walk, then you should at least be given the opportunity. And those people that were working were told that they should just get signed off, go off on the sick and take medical retirement. So that is obviously quite a depressing statistic. But actually, fast forward now, and I know many people who are in their 50s who are still walking, who are still working if they choose to. So again, even in that space of time, things are changing. They talked to health and social care providers, and there was this sort of argy-bargy between, it's a neurologist saying, but it's not our specialist. Geriatrician saying, no, it's a neuro condition. And then talk about this overlap between ableism and ageism. So you might face the stigma of being a disabled person, the ableism that you feel in society, and then suddenly you've got this additional thing about ageism. And actually talking about things like, so if I'm sending an older adult home and they need to get carers, the maximum carers I can really get is 4 times a day. So sometimes people who had cerebral palsy and had much more of a social care package, suddenly when they got to 65, it was like, actually, no, we'll just reduce you down to 4 times a day now. So there was this overlap in ableism, ageism, and the stigmas faced. So there are associations between cerebral palsy and ageing, and I sort of said predictable changes because even before I was a doctor, there was things I would have maybe guessed that might happen to me. I already fall more than other people, and I have been known to fall going into my falls clinic. And I was so embarrassed. I went in, and the man said to me, patient, Hen, I think you need to come to this clinic. Have you looked at your tights? And I had a big rip in my tights and my knee was bleeding, but I'd been so embarrassed I hadn't checked. So the irony of me doing a falls clinic is not lost, but we are 6 times more likely to fall, and that's because we have impaired gait and we have impaired balance. We've got increased risk of osteoporosis, increased risk of OA, which is osteoarthritis, so that's the wear and tear type of arthritis, and that's because we walk and move in different ways that probably challenge our joints and our bones. Fatigue is a problem that is common to people with cerebral palsy, and that increases with age. So living with cerebral palsy, just getting on with your day-to-day activities, you probably exert about 3 to 5 times more energy than somebody who doesn't have cerebral palsy doing those same activities. So it's little wonder that we have fatigue, but you add on top of that increasing pain, which can cause more challenges to sleep, and then that becomes even more of a problem. One thing that I wasn't aware of when I was younger was this notion that as I say, we talk about it being a static condition, but actually people report declines in gaits in as young as 20 and 30. Not everybody, but some people, and without getting support to try and help with that. And then we talked about increasing pain, and the pain can be different. So we have things, you can have pain associated with spasticity, so the tight muscles. But as we get older, we might have pain associated with that wear and tear. So osteoarthritis type pain. Might also get pain associated with osteoarthritis. So there's lots of different types of pain that we can get that perhaps become more tricky as we get older. There's loads of things I could talk about, loads of changes that happen as we age. I could talk about continence, I could, lots of things. So I've just picked out a few. So falls increase as we get older, and there's a number of reasons why that happens, but we know that if we take a multifactorial approach, so that means we look at lots of different things in the older population, then we can reduce the likelihood of falls, we can increase confidence. So that might be a geriatrician like me looking at it, as well as a pharmacist, as well as physiotherapy doing strength, gait balance, occupational therapist looking at the environment. So if you are someone with cerebral palsy and you start to fall, don't just necessarily put it down to, well, I've got to accept this because I've got cerebral palsy. If things are changing, look at things that you can do to reduce that risk. So keeping active, particularly focusing on things which improve your strength and your balance, and just moving more helps. Looking at checking your vision, because that can impact. Looking after your feet, so wearing appropriate footwear, going to the podiatrist if you need to. The Royal Society of Podiatrists now have guidelines on looking after adults with cerebral palsy. Medications can increase your falls risk. Now, sometimes we need to take these medications, but it's important to always think, do we still need to take them? Can we reduce dosages? Some medications that people with cerebral palsy might take, things like painkillers, particularly things like baclofen to reduce spasticity, the antidepressants perhaps, they can all increase falls risk. Now, that doesn't mean you shouldn't be taking them, but it just means we always need to consider reviewing them. And then thinking what you need to do to move around safely and how you can help with that, be that walking aids, being that looking at your environments, and making sure that you are eating and drinking well, because what we often see is older adults get dizzy when they stand up because they don't keep themselves well hydrated. They're maybe on medications to lower blood pressure. So there's lots of things to consider, and you can see some links down the bottom to help with both, if that is a problem for you. So I think the second message would be, people say, oh, if I just had a magic pill, I'd make a fortune for aging, and that magic pill is exercise or movement. And the chief medical officers for England, Wales, Scotland, Northern Ireland all have activity guidance for children, for adults, for older adults, and including disabled people. And disabled people are the same. So they recommend 2.5 hours of moderate intensity activity a week. That's quite a lot. So that's, your heart rate goes up a wee bit, you get a wee bit breathless, but you can still chat. And actually, that can be quite difficult to access if you're disabled. You can't just decide. There are lots of people with cerebral palsy, they go out running, but I can't run. So I can't decide just to go out and do a park run. I can't do most of the classes in the gym. You're more fatigued, you're more sore. So sometimes accessing activities is really, really challenging. But movement is really, really important. And I think if we look at it in movements, like what movements can help you, and I know that I've tried to do more exercise over the past wee while. And when I went to the physio, my hip movement was better, my back movement was better, I'm sleeping better, my pain's reduced. So it does help. They also talk about doing things to develop or maintain strength, and that's a couple of times a week. And that's because if we look at muscle, we talk about muscle mass and we talk about sarcopenia. So sarcopenia is probably one of the single most important things to think about when we talk about frailty, and that is your muscle mass. So your muscles are made up of skeletal muscle, and that's protein, if you like. And from the age of about 30, we start to lose our muscle mass, depressingly, about 1% a year. And then that starts to increase as we age. And there's various things that can speed that up. For example, if you become unwell with infections or other things, and we know that people with cerebral palsy probably have a little bit less muscle mass to start with. And you can see here, we've got a 40-year-old triathlete. I swim with a triathlon club, and it kind of makes me laugh because they all are quite intense about it. I'm sorry if there's any triathletes, but they are quite intense in their dedication to physical activity. But this is a 40-year-old triathlete, and you can see all their muscle is this brown skeletal muscle. And then if we look to a 74-year-old that's sedentary, you can see that muscle has been replaced by fat. But we can change that. And then if we go back to a triathlete again, 70-year-old, you see that they have not got all that muscle loss. And that's really important because that means that you reduce your falls, you maintain your function, your ability to walk, your ability to do the things that you want to do, reach up into a cupboard to get, whatever you want to get out the cupboard. And it's not just about maintaining your function, but it's also related to other things. So for example, if we look at where I work in the cancer setting, we know that individuals that have sarcopenia are less likely to survive their cancer, independently of what grade that is. So if we can look at maintaining our muscle mass, it's really important. And it's not just about, your cardiovascular stuff, but particularly looking at your strength training. Now, that doesn't need to be in the gym lifting weights. That can be using, just your own body resistance. It can be gardening. It can be carrying a bag of shopping. I do go to gym, but I also do some Pilates because I know that that's the difference between me being able to still get up off the floor myself, my back not causing me jip, and being able to fall over less. So there's lots of different things, and doing this strength work is really important, and trying to move as much as you can. And while there is huge challenges in accessing exercise, I think if we just think about it as movement and not thinking about the number of hours, but just moving as much as we can in whatever way we can is really beneficial. We also think about osteoporosis. So osteoporosis is more common as we get older, but there are a number of risk factors associated with that. And we know that people with cerebral palsy are more prone to osteoporosis. That might be because we don't weight bear as much, so we're not walking around as much. It's associated with some types of anti-epileptics. And that means that the bone is not as strong, so you're more prone to fractures. And there are medications that we can give to strengthen the bones. So if you look on the Royal Society of Osteoporosis, they have a little calculator that you can do, particularly as you're getting older, to sort of calculate your risk. And then you can think about doing something called a DEXA scan, which looks at your bones. If you have had a broken bone as you're getting older, from what we would call a low impact injury, so just say you fell off a chair and you broke a bone, then maybe considering that. And we can all take vitamin D, so it's recommended that we take vitamin D from September through to April, because obviously here in Scotland we really don't get enough sun. There are also sort of less predictable changes. So we know that if you've got cerebral palsy, you're more likely to have an increased mortality due to cardiovascular diseases, and that's things like heart attacks and strokes. There is also increased risk of having things like type 2 diabetes, which is associated with these increased risks of heart and stroke disease. So again, there's things that we can do. So thinking about the lifestyle things, so maintaining a healthy weight. Some people with cerebral palsy, particularly if they've got lots of spasticity or abnormal movements, trouble with swallowing, can be underweight, which isn't good for your muscle mass, but also associated with being overweight. So it's important that we try and maintain a healthy weight. BMI, which we use, is maybe not as good for people with cerebral palsy because of the disruption in muscle mass. So what we do is talk about a waist ratio. So your waist circumference should be no more than half of your height. So that can maybe be another marker. Thinking about not smoking, balanced diet, all the kind of boring things, moderate alcohol intake, physical activity will all help with those cardiovascular risk factors, diabetes risk factors. Someone did ask me at the conference after, so I thought I'd mention it. Is there an association with dementia? So, for example, with Down syndrome, we know that there's an association with an early onset dementia. There is nothing like that in cerebral palsy. It's not associated with dementia, although I guess some of the risk factors we talked about, things like smoking, can make you at risk of some types of dementia, like vascular dementia. So taking care of those risk factors is important, but there's no actual association. I think people get really frightened by dementia, so If you are noticing changes in your memory, it's not always dementia. There are other things which can contribute to that: thyroid disease, mood, memory. So getting that checked out is always important. Well, we know that there's cardiovascular, respiratory diseases are more common and you're more likely to die from them. Cancer isn't more common, but you are more likely to die from cancer if you have cerebral palsy, which is a bit strange, and we don't really know why that is. Some of it might be, for example, that we know that if you've got cerebral palsy, you're less likely to access cancer screening. And this was, there was a NHS Geriatric Glasgow and Clyde certainly had a campaign recently on how they could support people with learning disabilities to get their screening. So if you are struggling to access screening, then do speak to your healthcare professional about how they can support you to access that. If we think if you're a female, you should be checking your breasts for lumps and bumps. That might be trickier. So thinking about how you overcome all these barriers, getting help to do that is really important. So my sort of take-home message 3, and I'm actually rubbish with this, I put everything down to cerebral palsy, but if you're noticing that things are changing, if you're struggling to do things, if you're feeling more tired, then do see someone about it. It might be your cerebral palsy, and there may well be things that can be done to help, but it might not be, and that's called overshadowing. And sometimes that can be the person with cerebral palsy themselves, always putting it down to their cerebral palsy, that's me, or it can be healthcare professionals. One example of this would be, I saw a man who had cerebral palsy, he had hemiplegia, he walked with a quad stick, and he was on a bus, and the bus braked, and he fell over, and he landed on his hip. And he went to ED with hip pain, and they did an x-ray, and there wasn't a fracture. But sometimes fractures don't show up on x-rays. So he then struggled to walk, and they just kind of sent him home in a wheelchair thinking, well, because he's sore and he's got cerebral palsy, he can't walk as well. And off he went. And then actually it transpired that he had a hip fracture that just didn't show up on the x-ray, because people just sort of presume that because he had cerebral palsy, not being able to walk as well when you're pain is just kind of normal, versus, and that's that kind of example of overshadowing. So it can be healthcare professionals, not because they're bad, but just because they maybe don't understand about cerebral palsy, or it can be those of us with cerebral palsy ourselves. There are lots of guidelines now that can help healthcare professionals help people with cerebral palsy themselves. So the NICE guidelines, so NICE is an English NHS or England organisation, or an English organisation that gets all the experts together in the room and looks at the best guidelines and best research to see what should be happening for a group of people. And there's NICE guidelines on lots and lots and lots of things. In Scotland, we've got SIGN guidelines. We don't have a SIGN guideline for adults with cerebral palsy, but this would still be applicable. So it looks at things like service organisation. So it talks about if you've got a deterioration in your function, then you should be referred to a multidisciplinary team. What do I mean by that? I mean people that be able to help you, not just doctors, physiotherapists, occupational therapists, social workers. Also, if you're going to get a procedure, for example, an orthopaedic procedure, it talks about allowing people with cerebral palsy to access different pathways, not even specialist pathways, but for example, using wheelchair services that may help with them. Talks about transition of care, which, as I know we talked about, that's really challenging because often there's nothing to transition into. It talks about getting regular reviews of your cerebral palsy, particularly if you're that grade 4 or 5. I'm thinking about sort of annual reviews and what that might involve. It talks about function and participation, so it talks about communication. It talks about vocation and independent living. So what are the barriers to people with cerebral palsy accessing work and accessing independent living, and what can be done? The use of technology, the importance, as we talked about, in accessing physical activity and how we support that. And it talks about orthopaedic surgery. So at what point when you're having problems with your bones and your joints, should you be referred to an orthopaedic surgeon, and what type of orthopaedic surgeon? It talks about managing abnormal muscle tone. So we talk about spasticity. So that's the tightness of muscles that we get. And there are sometimes you don't need special medicines we can be aware that different things can trigger spasticity to go up. It might be because we are stressed, not doing as much. It might be due to increased pain. It might be due to infection, might be due to constipation. So what are the things that we can do to improve spasticity without taking medicines? Talks about what medicines we might want to use, something called baclofen, when we might want to use that, when pain's a problem, when it's limiting function, and then when you might need to be referred to what we call a specialist spasticity service. And that's doctors that are experts in that, and they use things like botulinum toxin, Botox. And then it talks about the assessment and monitoring of the clinical complications and comorbidities. So the things that we talked about, the problems with your bones, the osteoarthritis, the osteoporosis, mental health problems like mood and anxiety, eating and nutrition, if you're underweight, what can we do about that? Talks about respiratory problems. So if you have swallowing problems, problems with posture, problems with secretions, you might be at increased risk of pneumonias. What can we do about that? We'll talk about making sure you're up to date with your vaccinations, making sure that you've done a speech and swallow assessment to make sure you're on a proper diet, all these kind of things. And then talking about pain and the different types of pain that we've talked about and what we can do about that. So these are really useful guidelines, even as someone with cerebral palsy, as a parent, as a carer, as a partner, as a healthcare professional to have a look at. The all-party parliamentary group had a number of things it looked at. So there was a section on education, there was a section about accessing education and work, and then there was a section about health inequalities, and there was 3 of us that gave evidence to that verbally, and then there was lots of written evidence as well, and it came up with essentially a statement of what should be provided. And I say a lot of this is aspirational because this is what we should have and what we want, but of course what we need is the resource to follow that so that these services start to appear across the country. And I guess that's the challenge, isn't it? And then just if you are someone with cerebral palsy, if you're a healthcare professional, and the Adult Cerebral Palsy movement have produced things for general practitioners, because GPs are, I think, kind of unsung heroes. They see the vast majority of people in healthcare settings, but get the least amount of resource to do that, and they're expected to know about every age group, every condition. So they are not going to know everything about cerebral palsy. So there is a really useful resource about if someone with cerebral palsy comes to you, like what can you help them with, and what do you need to look at? I think if you are going to your GP, rather than just going to say, no, I want an annual review, thinking about, well, what actually are you struggling with? Is it pain? Is it sleep? So that they can help you. And then, of course, Cerebral Palsy Scotland has vast amounts of resource, thinking about just simple things like accessing exercise. They've got vast amount of, I contacted them because I wanted to try rowing, and they came back with all this information about how I would access rowing. You know, if you want to know how to learn to drive, they can tell you about special driving lessons. There's a vast amount of resource there. There's lots of things throughout that is there to help you move better. Inclusifit is a girl who is a personal trainer who has got cerebral palsy, and she runs online seated exercise programs. There's vitality classes across the council areas, particularly for older adults with other health problems if they are falling over, to help them maintain their strength, their gait, their balance. There's Glasgow, which is a seated yoga charity which runs yoga throughout Glasgow. So there's lots of things that you can access, and accessing Cerebral Palsy Scotland, reaching out and asking them for help and what you're struggling with, and I think Stephanie would agree, she would be happy for that. Talking a little bit about the barriers. So I mentioned EDI, which is equity, diversity and inclusivity. And obviously with the way that current politics are, that's getting a bit of a hammering. And I will never apologise for talking about how important this is. This is human rights. If I was to do research into a cancer treatment that was going to help people live longer, no one would argue with that. But if we are looking into researching why people from certain protected characteristics or from certain levels of deprivation die sooner, and we can find solutions to that, Why is that any less important? It's not. It's about access to healthcare. It's about access to education, employment, housing. So people with cerebral palsy who walk like myself will know the challenges of shoes. And when I was wee and going to school, everyone had these, like, in my head, they were called princess shoes from Clark's. I don't know if they were, but the advert must have had a princess in it. And there was a little key, and you got a little key. And I really wanted to wear those shoes, but I used to walk on my toes, so I'd scuff through shoes like nobody's business. So I couldn't get these shoes, and instead I got these chukka boots, and they had steel toe caps, which were obviously very functionally good, but I was mortified. So equality is this idea that everybody is getting a pair of shoes. So I could have got these princess shoes and they would have been absolutely no good for me. Like, I would have walked out them, I would have fallen over, and I would have scuffed them, the hole in them, in 2 days. Diversity is everyone getting a different type of shoe. So I got a different type of shoe, and I got a pair of shoes that met my needs, so it fitted. But then the challenge is this inclusivity. So knowing that I could walk into the playground with my slightly different shoes on and not get teased and feel that I fitted in and things was a challenge. And I think that is probably the challenge that we all feel when we have cerebral palsy, when we're out in the world. And we need to accept, and we need to recognise that being disabled is hard, not just because of physical challenges that we have and the pain of all those things, but all the other things. So more likely to be unemployed, cost of living is higher. This was pre-COVID, that was 500, pre-cost of living, so it's about £583 more a month if you were disabled. It can now be up to £1,000, and obviously that differs depending on your energy needs. So if you've got a tracking hoist in your house and you use more energy costs, we know that you're more likely to live in poverty. And as well, this sort of attitudinal stuff about that 1 in 3 people see disabled people as less productive, and 3 out of 4 disabled people often experience negative attitudes over the past year. And we also know there's barriers to healthcare, and this is World Health Organization. So the kind of attitudinal barriers that even healthcare professionals have, and like, as a disclaimer, I'm not perfect either. So communication barriers. So I had a lady on my ward that used BSL to communicate, but I thought she could lip read, and we couldn't always get a BSL interpreter. So I would talk to her and she would kind of nod, and I think that was fine because I thought she could lip read. And then she went to another appointment, embarrassingly, with a surgeon, and she was like, yeah, I just don't feel like I know what's happening because, you know, this doctor never uses BSL. So, you know, there are communication, and even, you know, I've made mistakes with that as well. The physical barriers, I work in one of the hospitals I work in is Glasgow Royal, is an old Edwardian hospital. If you're trying to get parked in the blue badge space during the day, it's a nightmare. The lifts are always breaking. They had to move my office from the 4th floor to the ground floor because it broke so often. At one point I was in crutches. It was just like, I'm spending more time waiting for a lift than I was doing anything else. And then the financial barriers we've talked about, and then recently the report which showed the huge challenges that disabled people face in using public transport. And it was like 7 out of 10 people face challenges every time they try and get on public transport, because buses don't stop, and lower for wheelchairs to get on. Like, how many train stations or tube stations in London only have steps or escalators? These are just a few things. Anyway, I wanted to finish on a positive again. And so this is Guy, and his story has been like literally all over the place now because it's a really powerful story. And I think patient stories are one of the most powerful things if we're trying to win over hearts and minds. So he was a 73-year-old man when he came to me who lived with spastic quadriplegia. I did a general clinic at that point. He'd been referred by his GP with weight loss. The worry about that is that you've got something else going on, like cancer. He had a history of bowel cancer. So I guess it was good that they weren't doing that overshadowing thing. He had a really feisty sister who I really liked, and she had been his carer all of his life, and she was older than him. She was in her 80s by this point, and she said, like, no one had bothered with him. His mum had been told that he wouldn't live beyond the age of 12, so essentially he got to 12 and that was it. Nothing had happened. And he sort of said, literally and metaphorically, no one had listened to him. He had difficulty with his speech. He'd never been given any aids to help with that. And no one had ever actually listened to the challenges that he faced or helped him overcome those challenges. He used a wheelchair, He required assistance with all of his activities of daily living, extended activities of daily living. He had no formal carer. His sister did all of that for him. So what we do in geriatric medicine is something called comprehensive geriatric assessment. So that's multi-dimensional, interdisciplinary. So essentially, a fancy way of saying lots of people, geriatrician, nurse, physio, occupational therapist, social worker, whoever we need, and it's a process. And we look at a frail or older adult's medical conditions, mental health problems, social circumstances, and function. And so you might come in with a fall, but then what we'll say is, oh, actually you've fallen over because you've got a pneumonia, but what we notice is your blood pressure drops when you stand up because you're on too many blood pressure medications. And actually you've maybe got a wee bit of cognitive issues now that mean you forget to use your Zimmer frame. So we'll look at that as well, and we'll look at what we need to put. So we do all of those kind of things, and we plan and carry out a holistic plan for treatment, rehabilitation, and then long-term follow-up. And the evidence base for that is really strong. So we know that you're more likely to be alive and in your own home than if you don't get that. So that fear of coming to a geriatrician hopefully helps to know that that's what our goal is. And we use that, for example, in the cancer setting. So we know if you're a frailer older adult and you get comprehensive geriatric assessment before treatment, you're more likely to get through and tolerate that treatment. So we did that on this gentleman. I referred him to Cerebral Palsy Scotland for a sort of specialist physiotherapy and occupational therapy, and they liaised with the local physiotherapists and occupational therapists to help them deliver a programme for him. We referred him to Westmark because his wheelchair was really not helping his posture. He was all off to one side because it wasn't, and he got a new one. And they even put like a fancy handle so it was easier for his sister to push it. He was referred on to orthotics for a new raised shoe, because actually his shoe was kind of talking at you because the sole kept falling off. We referred him to speech and language therapy. For the first time in his life, he had a communication device and he was put on a staged diet. And we referred him to the dietitians. I looked at causes of weight loss, like cancer, things like that. And actually it wasn't. It was related to his cerebral palsy. His swallowing had declined, so he wasn't really eating. His mood was down because he was in so much pain and he wasn't sleeping well. So actually looking at his cerebral palsy, taking this multidisciplinary approach, meant that his posture improved, his pain went from 7 out of 10 to 3 out of 10, his sleep improved, he gained weight, her stress was reduced because we put in place some support for her, his mood had improved, and his function improved. And in fact, he was able to he went to a club and he didn't use the wheelchair, he used his 4-wheel relator, and actually being able to increase his movement also helped with his posture and his pain and things like that. And obviously it was a great outcome for him, but I felt quite tragic that he'd spent all of those years not getting the treatment that he needed to optimize his function. And so thinking about the barriers that he faced, recognition that cerebral palsy was not just a non-progressive condition, but it was something that's not static and changes and you need support through life. Lack of education and research, specialist care, societal attitudes that you should be grateful of the fact that you live beyond 12. And I guess valuing some of the services that those of us with cerebral palsy need, things like rehabilitation, which are kind of getting eroded because it doesn't fit into your 4-hour wait list or your wait list times and things like that. But as you can see from this gentleman, it is never too late to improve. So even if you're in your 70s, your 80s, your 90s, it's never too late. And I met his sister actually really recently, a year or so ago, a couple of years ago. She was 90, she was in the hospital, and he had sadly died, but he died when he was 80, he had a stroke. And I had asked his permission to share his story. So I kind of shared with her the fact that his story had been in like Westminster and all these fancy places, and she was very pleased. So yeah, that is me finished, and I'm happy to answer any questions as best I can.
Hi, everyone. Thanks so much, Kirsty, for that fantastic presentation. It covered so much ground, and I'm sure there was a lot in there for everyone. There's been questions coming in, so I'll quickly put the first one to you, Kirsty. I think the first question was about physical therapy, and the question was about what's the best physical therapy programme for somebody with level 2 spasticity.
So I suppose I'm not a physiotherapist, so actually the best thing to do would be to see a physiotherapist who will be able to give you advice about physical activity. If you're talking about things like exercise, because I take it level 2, probably similar to me, you probably know your own body pretty well, and you kind of can know the things that you can do and you can't do, and the things that are helping you and aren't helping you in terms of movement. And as I say, I have got that wrong quite a lot in the past, but I think if you're not sure, the main thing to do would be to see a physiotherapist. But if you are wanting to do exercise, so things like that, InclusiveFit, who is the personal trainer who has cerebral palsy, she's specially trained in disability. She lives down south, but she does online stuff. Things like vitality classes within the council areas. They are people that are specially trained to deliver exercise programs to people with additional health requirements, whether that is respiratory problems, heart problems, neurological conditions. So there are things out there, and I can share some of those links if people want.
Thanks, Kirsty. I know we're quite tight for time, so I'll press on. Somebody asking a question about exercise. When looking at exercise, is it the endurance aspect or the muscle strengthening?
So it's the muscle strengthening. So the cardiovascular stuff is really important for your heart health and things like that. But in terms of probably the muscle mass, the strength work is probably the thing that's really important, and doing that kind of a couple of times a week is something that we're seeing increasing evidence base for. So putting that into your exercise regime is probably important.
Thank you. Next question. Is there any group of orthopaedic surgeons who are interested or developing practice in doing hip, knee, ankle ops for people with CP?
I don't know is the honest answer to that. There is a Royal Society for Orthopaedic Surgeons sort of guideline. I have had orthopaedic surgery. I think if you but in terms of, is there like a orthopaedic surgeon whose specialist interest is cerebral palsy? I did ask one of my colleagues about this when I was doing the talk. She wasn't sure that there was, but so I don't know, to be honest, but there is an increasing understanding within orthopaedic circles that about different techniques that you might use for people with cerebral palsy.
Thank you. And then I think this might be the final question we can get to, and I don't know, perhaps once Kirsty's answered, maybe Stephanie would want to chip in. The question is, how do we find out more about the services that have been discussed, and how do we get referred?
So impact of menopause and cerebral palsy, I didn't touch on because most of the patients that I see have gone through menopause by the time they come to me. But yes, there is information about menopause and cerebral palsy on the UP website that I signposted. There's a special bit about women's health, and there is a bit about menopause, so you can look that up. In terms of services, so there isn't a specialist service for older adults with cerebral palsy, but there will be services that you can be referred to regardless of whether you've got cerebral palsy. So for example, if you're older, over 65 and you're falling over, you could get referred to a falls clinic like myself. If you're having difficulties with functional activities, you might get referred to the community rehab team, and your GP would kind of be the first point of contact for that. So it really depends, and your GP would be able to signpost you. If it's about spasticity, for example, if you're in Glasgow, then there's a spasticity service at the physically disabled rehabilitation unit, and that's between the rehab physicians and the stroke physicians. So it would very much depend what the issue was. There may well not be specialist services, but there may be other services that can help you, and it would depend what the issue was.
If I can just come in on that, we on Cerebral Palsy Scotland's website, we have a directory for sharing information about services that we know about and support people with cerebral palsy in Scotland and sometimes in the wider UK on our website. We also have a resource that is for professionals, which we call our CP link, which is quite often we find that professionals in different areas of practice don't know what is available or what the referral criteria to some of these services may or may not be within Scotland. I have to say it is within Scotland. Where we do know what the referral criteria is and who the best contact for any service, that is on our CP link directory, which is not published because we have to keep it up, keep it up to date because it changes quite regularly, and we do our best to keep up to date with it based on our experience. But we are really happy to share our knowledge with any referring professional that wants to get in touch with us. So Anna, is that all the questions?
Yeah, I think we're kind of up to time now, so I think we've covered.
I think we've gone 5 minutes over, but I think it was well worth it, and I'm so impressed that everybody is still here. Kirsty, it just is a testament to actually how important this subject is, how delighted we are that somebody like you is shining a spotlight on this. And, whether you are a person with CP, whether you have a family member with CP, whether you are a professional, or whether you're just on here because you're just really interested and you want to spend your Tuesday night talking about CP because it's CP Awareness Day, it is a fantastic session. Thank you so much for giving up your time, Kirsty. And thank you to everybody who has been on this event. As Anna said, I think in the chat or earlier, we will plan to put this up on the Cerebral Palsy Scotland YouTube channel for a set period of time. So if you want to signpost it to anybody else, do so in the next couple of weeks or so. And if there's anything that we haven't covered that you would like to raise, either with us or with Kirsty, please contact us through the contact button on our website, and we will try and answer as many queries as we possibly can. And if you're in Scotland, please just come and see us. So thank you very much, everybody, for a fabulous evening. And thank you, Kirsty.
No problem. Thank you for having me.
Bye, everybody.
Bye.
Bye, everybody. Thank you.
Yeah.